Okay, we are back for the last piece of the lower extremity anatomy, the ankle and foot. The requirements of the ankle and foot are mobility and stability. Stability is needed to provide an adequate base of support and also to function as a rigid lever for pushing off when walking. And mobility is needed to adapt to the uneven terrain, absorb shock from the ground, and neutralize those forces from up the chain. We have motion in the cardinal axes here. So this is the frontal plane, the y-axis is the transverse plane, and the z-axis is the sagittal plane. So we're going to break it up into ankle and foot. So first is the ankle, the tibiotarsal joint. It is a hinge joint with only 1 degree of freedom. It is very tightly interlocked, and the movement is in the sagittal plane. So flexion and extension is what is happening there. Extension is going to be greater range of motion than flexion. And just for this PowerPoint, they are labeled. So flexion is dorsiflexion and extension is plantar flexion, because extension is typically when the bones are moving apart. So plantar flexion is actually not named properly, so it will be extension in this PowerPoint. The articular surfaces of the ankle, so it is the talus and the tibia. So the superior surface of the talus is convex anterior to posterior, and it corresponds with the reciprocal part of the tibia here, which is going to be concave, and they both have this ridge in the middle that goes longitudinally. And then on either side, we have a medial and lateral gutter. And on the medial side, it is planar, and it is articulating with this medial malleolus. And then on the lateral side, it is also planar, running more obliquely and interacting with the fibula here. The ligaments of the ankle are shown here. So when you sprain your ankle, most commonly, it is the lateral side that you are spraining. And I wanted to talk about, so this anterior tibiofibular ligament is under the greatest strain in plantar flexion, and these posterior two are under the greatest strain in dorsiflexion. So if you are looking at ligamentous laxity and you do it, you want to make sure you look at it in both dorsiflexion and plantar flexion, so you're able to see if there's any reactivity of any of those lateral ligaments. The transverse stability of the ankle depends on a very tight interlocking that's needed, and so that's a bimalleolar pinch from both sides, and that happens because of the ligaments that are there. And if that stability is compromised, you can have any of these different scenarios. I wanted to point out, so adduction of the calcaneus is less common in terms of getting a fracture. It's less common because the ligaments typically sprain, because that would be the lateral side that's stressed. Where here, if it goes into abduction of the calcaneus, you're going to more commonly get fractures because it's a bony end feel there, and that is going to result in some of these different scenarios. The factors that limit flexion are shown in this picture. So the first thing is bony, so the talar neck on this anterior margin. Posterior has a capsular and ligamentous restriction, and then the thing that normally is the most restrictive is the muscular factors from the triceps surae. So it's typically limiting it before these two are. So just a side note, if you want to do an intervention that addresses two of those things, so not the bony part, you could do a mobilization with movement at the pulley. So you'd be facing the pulley and you have their foot on a slant board, heel on the ground, and put the strap around the distal tibia. And then you want to have them bend their knee. So it's doing, the weight is doing an anterior glide, which would be a posterior glide of the talus. So you could address two of those three factors at least. It's one of my go-tos. And so then let's go to extension. So the limiting factors here are bony first as well. Then there's the anterior capsule and collateral ligaments, and muscular is always the first, or typically the first to limit as well, the flexors. And then here we're looking at anterior posterior stability of the ankle. And the factors that allow it to coapt is first it's gravity, and then this anterior and posterior part of the tibia, the structure of it helps prevent the talus from moving anterior or posterior. and then these collateral ligaments as well, and they are assisted by muscles that are not pictured. And then if flexion or extension exceeds the normal range of motion, you can get, one of those factors are going to fail. So you can get any of these different scenarios here. The tibiofibular joint. So there is the superior and the inferior or proximal and distal joint. So the superior part has this biceps femoris that comes in and attaches. And then the inferior part is the syndesmosis, and we have the interosseous membrane that attaches the whole way. So it's going to allow those two joints to really move as one. And what happens when they're moving? So here we're going in dorsiflexion. So the inferior is the first that's going to be recruited in both motions. And this posterior tib-fib ligament is going to act as a hinge for the motion. So the lateral malleolus is going to move laterally because the trochlea is smaller posteriorly than anteriorly, and that intermalleolar space is going to increase when it moves away. And then it's going to laterally rotate and be pulled superiorly. And so then at the proximal joint, it's going to go superiorly as well, and it's going to gap medially. And then with plantar flexion, it is going to be the opposite of that. Now we are on to the foot. So it performs a dual function. It is orienting the foot to the other two axes of motion so that the sole of the foot is correctly presenting to the ground. And it's altering the shape of the curvature of the arches of the foot so it can adapt to those irregularities. And part of that is the shock absorption and creating greater elasticity. The rotation of the foot, so same axes here, but now we're talking about these two more. About this y-axis is going to be abduction and adduction. About the z-axis is going to be supination and pronation, but obviously noting that this is the primary plane they're moving in, but they are all motions are triplanar. So adduction is going to be accompanied by supination and extension, and abduction is going to be accompanied by pronation and flexion. The subtalar joint. So the talus is unusual for three reasons. One is that it's considered a caged bone, so it has no muscular attachments, but there are all these muscles that run around it from the leg to the foot. And then it's the stress distributor. So all the body weight's coming down, and the talus distributes it posteriorly and anteriorly. And then it is entirely covered by articular surfaces and ligamentous insertions, so it's considered a relay station. And there are 3 articular facets here. So on the calcaneus, the posterior facet is convex and the talus is concave, and then it's the opposite here for the front two. So the middle and the anterior, on the calcaneus it is concave, and on the talus it is convex. And because of how they are designed, there's only really one position for it to be in perfect congruency, which is ideally that weight-bearing position where they can transmit its forces entirely. And that's where gravity will really coapt the joint, and all of those other positions are unstable and associated with a variable degree of articular incongruence. Subtalar motions are triplanar, so we'll talk about all 3 motions, but this is the axis, it's called Hankey's axis, that those motions, if you were to deduce them to one axis, this would be the axis they are moving about. So the arrows match what's happening up here. So if the calcaneus movement on a stable talus with inversion, you would have anterior translation, you would have lateral rotation, and medial displacement. And then the opposite would be what would happen for eversion. The transverse tarsal joint, so that is our talonavicular and our calcaneal cuboid joint. And so the calcaneus is concave superiorly and convex inferiorly, and the cuboid is actually reciprocal of that. And then the talus is convex and the navicular is concave, and the navicular and cuboid have a plane joint. And then there are ligaments that surround all of these joints that are shown in these pictures. The transverse tarsal motions. So we're gonna have, this is inversion as well, so supination. The navicular is gonna glide medially and inferiorly over the talar head and medially rotate due to the pull of the posterior tib. This motion increases that longitudinal arch of the foot and is checked by the dorsotalonavicular ligament. This is increasing the compression of the navicular through the head of the talus, thereby increasing the stability of the arch of the foot. And then the cuboid is also gliding medially and inferiorly over the calcaneus and rotating medially on the navicular and the calcaneus. So just to note, I think it's kind of counterintuitive that the navicular is moving inferiorly to increase the arch height. So if you are trying to increase the arch height in a patient, you want to make sure there's enough inferior glide. The role of the ligaments during inversion and eversion. So inversion is limited not by anything bony, but by ligamentous structures only. So there are two lines or two chains of ligaments that limit this. So the first one starts at the lateral malleolus, and it runs along the anterior band of the LCL and forks to the calcaneus and the navicular. And then the accessory band actually starts from the medial malleolus. And then eversion is limited by bony structures primarily, but it also has two lines of tension from the ligaments. But bony-wise, it had the posterior facet of the inferior surface of the talus slides down the calcaneus and hits the superior surface of the calcaneus at the floor of the sinus tarsi. And the lateral cheek of the talus is pulled laterally and hits the lateral malleolus. So if you are doing a mobilization for the calcaneus, if you're doing a medial mobilization, like you probably will never feel a real end feel, but if you are doing a lateral mobilization, you want to make sure it's not a bony end feel that you're pushing into, because that is what it's limited by primarily. You want to make sure it's something you can actually change. Okay, all these tarsometatarsal joints. So these are tightly interlocking joints, and they're all plane, and there's lots of ligamentous support surrounding them. To note is that this first and fifth metatarsal work kind of like in a triangular pattern. And so when they flex the metatarsals, when you flex the metatarsals, the curvature of this anterior arch increases. And when you extend them, it's flattening that anterior arch. Now we're into the muscles. So extension of the toes. So there's one intrinsic extensor. So that's the extensor digitorum brevis. It's thought to be the only true toe extensor because the other two are extrinsic, the extensor hallucis longus and extensor digitorum longus. And here we have all the different interossei, lumbrical, plantar muscles. Showing all the different layers here. So these intrinsic muscles of the foot are stabilizers of the toes, and they are dynamic supporters of the transverse and longitudinal arch during gait. So if they are not turning on, you will see a lot of different compensations. But one other thing is that the flexor hallucis brevis and the abductor and adductor hallucis are powerful flexors of this big toe, and they play an important role in stabilizing it during late phase step, so while you're walking. And then I wanted to include this picture. So if you were doing soft tissue work on the foot, sometimes it's hard to know what you can actually reach. So looking here at what the superficial structures are, you probably could get to the flexor digitorum brevis, longus, obviously going through the plantar fascia and this extensor digitorum longus as well. Are lots of different fibrous tunnels in the ankle, but I want to talk about this inferior extensor retinaculum here. So it acts as a hinge of a pulley for these muscles. So they are able to work most effectively because of this retinaculum. So if someone has been in a boot or something where potentially they're not gliding as well, it could be like a rusty hinge, if you will. And so potentially using a tool or something to break up any of the fibrous like any adhesions that could be in there will help you get more mobility out of those muscles. The flexors of the ankle are the muscles that lie in front of this x-axis here. And then which side they're on for the z-axis, they also do different motions. And so in order to get pure dorsiflexion without going in or out, these muscles have to be balanced perfectly. And then over here, if this is a picture, so if the interossei are paralyzed, so they are no longer stabilizing the metatarsals and the toes, then when you do dorsiflexion, you're going to get this claw-like deformity. And so this is actually a pretty common presentation of toes of people in Florida, I feel like, or just in general. You see them a lot in flip-flops, potentially due to the fact that we're in shoes a lot, the interossei muscles might not be turning on a lot, and then kind of clawing to keep those flip-flops on. And so here, this is the way we are supposed to stabilize. So this is stabilization of the big toe by the flexor hallucis longus and abductor hallucis, so that the extensor hallucis longus can just dorsiflex the ankle, which is different than in this picture. This should be in dorsiflexion, but the flexor hallucis longus and abductor hallucis are paralyzed. So then when you do dorsiflexion, it's getting this little claw toe. The extenders of the foot are shown here. There are technically 6 muscles that do this, but the triceps surae is the only ones that do it efficiently. So there are 3 muscle bellies that insert into the Achilles tendon. They are most efficient with the knee extended and the foot dorsiflexed. And then over here we have the other extenders. And just to note, we'll go into them more, but same idea as the previous slide. So on both sides of this axis, these muscles have to be balanced in order to get pure plantar flexion. The abductor pronator muscles. So we have the peroneus brevis, and it is more effective at abduction than peroneus longus. And it also produces pronation of the anterior half of the foot. Peroneus longus does do abduction, and then it produces extension indirectly by lowering the head of the first metatarsal. It also produces extension indirectly by pulling the first metatarsal laterally so that the medial and lateral metatarsals form one piece. That allows the triceps surae to act on all of the metatarsals at the same time. Therefore, if the peroneus longus is not active, it would only act on the lateral metatarsals. So if you are doing a heel raise test with a patient with their shoes off, and you're watching where they come up to, so you could cue them to come up all the way to their first metatarsal, and so you're watching, are they actually able to? Most people come to like second, third metatarsals, so if they can't get to their first MTP head, then most likely the peroneus longus is not doing its job. And an intervention, it's hard for people to just do that. So if you put a quarter under the head of the first metatarsal, that's a really good tactile cue for them to get all the way up. And it also is a pronator, as it lowers the head of the metatarsal arch and elevates the lateral arch and lowers the medial arch. And then this, we know that it does this, but this is a study that looked at a cadaver for the peroneus longus. And it just showed that it really does shorten the length of those 2 arches. Even though that's not in weight bearing, it was pretty cool. The adductor supinator muscles. First, we have the tibialis posterior. So it comes in and attaches to the navicular. It's pulling it medially, and it's a powerful adductor. It's producing supination and plays a vital role in supporting the arches. So it's concentrically producing supination and eccentrically controlling pronation. The tibialis anterior is going for flexion, adduction, and supination. It's more efficient as a supinator than an adductor. It's acting by elevating the structures of the medial arch. So it's lifting the base of the first metatarsal on the medial cuneiform. It lifts the middle cuneiform over the navicular over the talus, and all of that before it's flexing the ankle. So that is contributing to this medial arch. And I just wanted to point that out because I think when patients come in and it's their first visit especially, and we're trying to think of a home exercise program for them, I know a lot of times like a foot yoga, toe yoga could be something that we do, or like an eccentric for tendon healing, but sometimes if coordination-wise, that can be really challenging for patients. So seated, just active dorsiflexion, getting this tibialis anterior turning on, super simple in terms of coordination, but it's going to contribute to that medial arch. So depending on what they're coming in for, that could be a super simple thing to give them that would be very beneficial. And then, just noting that the tibialis anterior and posterior, so they're both doing adduction and supination, so you can get more bang for your buck if you are targeting both of those as well, just doing that motion. And then I included this study. It's looking at 34 women that have, half of them have posterior tib tendon dysfunction and how these muscles are turning on for them, different muscles. So this is a single heel raise. So this side is the patients with the posterior tib tendon dysfunction and then the control. And so they were not able to do the single heel raise as well, that fits, but just wanted to also point out, so they also had more weakness in hip extension and hip abduction. The plantar vault is this architectural structure that blends the elements of the foot into a unified system. So it's adapting to the unevenness of the ground, and it's really what's our shock absorber. So that it goes from the first metatarsal head, fifth metatarsal head, and the calcaneus back here. And they're all connected by two different arches. So we've got the medial arch, lateral arch, and the anterior arch. This medial arch maintains its concavity only with the help of the ligaments and the muscles. There are many plantar ligaments that unite these 5 bones, but especially the spring ligament and the talocalcaneal ligament are responsible for resisting violent but short-lasting stresses where the muscles cope with more of a sustained stretch. And I love these pictures here. So it's showing you the arch, where the muscles attach, and then which direction they're pulling and how that changes the arch. So the tibialis posterior is pulling the navicular inferior and posterior under the head of the talus, which points the anterior buttress of the arch downward. The peroneus longus accentuates the curvature by flexing that first metatarsal on the medial cuneiform. The flexor hallucis longus acts to support the arch by drawing the anterior buttress and inferior and posterior. And then this abductor hallucis longus spans the whole arch, so just contracting it accentuates the curvature from both ends. And so that is actually the case with the abductor hallucis longus and the abductor digiti minimi. And so the most bang for your buck is really getting those muscles to turn on in terms of increasing that arch height. So I know it's easier for patients a lot of times, like toe yoga wise, to get some of those other intrinsic muscles, but really focusing on the abductors is going to get more benefit for your patient. And the lateral arch is more rigid than the medial arch, which allows the force from the triceps surae to propel the foot forward. The rigid structure is maintained primarily by the superficial and deep fibers of this long plantar ligament, which prevents inferior gapping of the calcaneal cuboid and cubometatarsal joints when it's loaded. The fibularis brevis props up the anterior lateral aspect of the calcaneus by providing tension under the fibular trochlea. And the abductor digiti minimi again brings these ends of the arch together. The transverse arches span the whole foot, and we've got 3 different parts. So there's the anterior arch, which is the head of the metatarsals, and the abductor hallucis spans it. This is at the level of the cuneiforms, and this arch is supported by the tendon of the peroneus longus, so it exerts a powerful action on this transverse curvature of the foot. And at the level of the navicular, the curvature depends on the plantar expansion of the posterior tib. So those 3 muscles are really responsible for maintaining these arches. And then the longitudinal curvature of the foot also depends on the abductor, not also, I've already said this, but the abductor hallucis and abductor digiti minimi. The distribution of load. So this is similar to the picture from the talus earlier. So it's coming down through the subtalar joint, and then the talus is distributing it. Different sources say different percentages, but about 50% is going posteriorly to the heel. And then the other 50% is going forward at a 2-to-1 ratio. So 2 is going medially and 1 is going laterally. And then when you have loading through these arches, this is what's going to happen here. So pretty much they're moving inferiorly when they are getting weight bearing. But in general, the metatarsals are moving farther from the calcaneus under load. So it's tensioning that plantar fascia, both medially and laterally. And then for the anterior arch, it's flattening that arch, and then the forefoot's actually widening by about 12.5 millimeters. Putting it all together, so we know that the entire body is connected, right? Especially the lower extremity. You know, one thing always affects the other, and it's very easy to hypothesize how one thing can affect the other, but these are some articles I've found that actually show it. So tibial rotation significantly impacts pelvic position. And specifically, this study found that tibial internal rotation was the biggest factor, but this shows that calcaneal eversion couples with femoral internal rotation and an anterior pelvic tilt. And then unilateral and bilateral calcaneal eversion causes pelvic anaversion, and unilateral calcaneal eversion causes lateral pelvic tilt. So in general, just really it's all connected. So we want to have a stable foundation at the foot, and we want to have a stable core at the top of it so that the forces are distributed the best way they can be, right? The structures can work how they are designed. And that is it, guys. All right, it has been fun hanging with you. Thanks for doing this with me, and I am out.